Good afternoon, everyone. I'm Peter Stanton, publisher of the Worcester Business Journal, and welcome to today's webcast, which is From the Front Lines of the Crisis, a conversation with healthcare leaders from Central Massachusetts. This session and our full COVID-19 crisis webcast series is being sponsored by two community-minded organizations who have stepped up and helped us bring you this series, and that is Webster 5 and Fallon Health. We appreciate their leadership and commitment to bringing you and the several other thousand folks who have attended a webinar this whole series. A recording of this webcast will be made available online at Worcester Business Journal's website, so you'll be able to send a link to anyone who could not join us live today, or if you wanted to view it again. I'm going to be your moderator, and we have a terrific panel of four leaders from our region's healthcare industry joining us today. So please welcome Carolyn Jackson, CEO of St. Vinson Hospital. Carolyn, nice to see you. Richard Burke, President and CEO of Fallon Health. Hi, Richard.
Hi.
Dr. Tarek El-Sawi, the President and CEO of the Reliant Medical Group. Dr. El-Sawi, nice to have you. And Dr. Michael Gustafsson, the President of Umass Memorial Medical Center.
Good afternoon.
Hey, Michael. We're going to try and cover a lot today, including how our healthcare system has responded to the COVID-19 crisis. What is the state of care now that we're past the peak? Is it safe to go to the hospital, the doctor's office, and frankly, back to work? And what have been some of the consequences of the pandemic in terms of financial impacts, emotional impacts, and what else has been changing in a transformational way? So let's get started. The last 2 months for everyone, I'd like to hear from each panelist. Maybe we'll start with Carolyn. Last 2 months, it's been a whole new world. How would you describe the changes in your operations? And is there anything that surprised you about how your team has responded?
So at St. Vincent Hospital, we've had our command center open since, I believe it was March 9th. So that is definitely a change for us. And it's certainly the first time I think anybody has had a command center open that long. The biggest change, aside from being in a constant state of emergency preparedness and action, is really that we're making decisions much more rapidly than we ever have before, because the situation is changing daily and in some cases hourly, whether it's the number of patients, whether it's new medications that come online, new therapies, and it's forcing us to work in a very collaborative, multidisciplinary way. It's helping to break down barriers, and it's really making sure that we are nimble. We have a 1-hour change control process in place where when we make a decision to put something in place, we roll it out rapidly across the organization. And I think the thing that's been the most surprising is the level of innovation of people throughout the organization. Staff members all the way up to physicians saying, look, this is something that I think we could do differently. It's not quite working this way. Let's try it a different way. And actually being able to implement quickly has been great. So innovation, teamwork, and implementation in rapid cycle improvement has been just amazing.
Terrific. And Richard, how about at Fallon Health?
Yeah, similar to what Carolyn said, rapid change. We were deemed an essential business as a health insurer and as a direct provider of care for frail elders. And we had to, in a matter of days, go from having most of our employees working in our offices to having now 95% of our employees working from home. So that was a big change for us. We also had to implement changes in response to the pandemic, changes that would normally have taken many, many months, and had to do those within a matter of days in order to make sure that our members had access to care. So, for example, increasing, allowing for early renewal of prescription drugs, removing co-payments from telehealth visits, removing co-payments and co-insurance for all COVID-related testing and treatment. So those are changes that require changes to our system at the same time that we had moved 95% of our workforce home and needed to serve our members from a remote location. So that was the biggest change. And like Carolyn, I've been really impressed with the adaptability of our workforce and the ability to continue to serve our members even with that big change.
Terrific. And Dr. El-Sawi, how about at the Reliant Medical Group? What's been the change?
Peter, I'm not so sure that there's anything that remained the same. I think a lot of the things that Carolyn and Richard echoed, but there's, I would say that both of those things have been very much at play. But the part that's been incredibly gratifying during this process was the fact that everybody sort of realized in the community you're completely connected. And whether it was calls I made to Richard or to Carolyn or to Eric Dixon at Umass, the ability for all of us to work together is been something that really has been, doesn't surprise me, but it was very heartening. And I think the other thing organizationally, you realize how many barriers that you unintentionally have from getting people to make rapid decisions and empowering people to make decisions rapidly. Those to me were really the things, as soon as you figured out, we just have to let people get to being able to make decisions rapidly and course correct quickly also, has been a key and foundational change that I'm hoping that remains with us way after COVID.
Got it. And Michael, UMass has certainly been at the epicenter of this crisis, running a lot of the medical response. What's it been like from the inside for your team, you and your team?
Well, I would echo a lot of what others have said, particularly Carolyn. We're at day 80 of our emergency command center operation, which is truly unheard of to be running at that level for 24/7. And just to elaborate on it, a big part of that was to prepare our surge plans. I think what we had the advantage of, fortunately, was to learn from others. Starting internationally with the China experience, we really tried to learn from some folks in Europe. I remember we had a grand rounds from Italy, from critical care folks who were like at the epicenter. And it was so very helpful to hear their experience, and so that we could plan that much better. And then, of course, we learned from New York as we were developing our surge plans. And we could talk about this later, but we had a 22-step surge plan, and we got all the way up to step 19, step 20. So the planning and the amount of incremental expansion really paid off. And then it's hard to underestimate how differently we're functioning today. We're moving so much faster. We're having folks work with each other that have never had the chance to collaborate and work inside the hospital, across departments, across functions. And the level of innovation and creativity is it's so inspiring. It's really amazing.
Got it. So that's collaboration that if you tried to design it, it might have taken a long time, and it's been.
Yeah, I mean, we use stuff that would have taken us in a committee, 6 months maybe previous to sort out. We've been able to stand up a whole new function or activity in 24 or 48 hours. And so we definitely want to take that away as a way that we function going forward when things get back to normal.
Got it. So here's a question really for both you and Carolyn related to the role of our hospitals. Can you share with us, you mentioned you went 19 steps into 22. How close did we come to the capacity that you've set up? How is that, what's the trend line right now? And, what's been working in terms of the front lines of treatments?
Maybe if I can show the slide from Central Mass, if we could bring that up. That might help. But right now, we still have about 140 to 150 COVID positive patients in the hospital. The next slide. So we have about 140, 150 COVID positive patients currently still at Umass, the medical center. We had, at our peak, we had about 200 COVID positive patients. This chart is showing, as we captured daily census from all the hospitals in Central Mass, including St. Vincent's, Harrington, Holyoke, Milford, what the peak was. And you can see the peak of hospitalization occurred around May 1st. That was about a week later than the rest of the state. And then what you also notice is that it's not a sharp bell curve on the other side. We're still just gradually coming down. So we're still at a 250 patients. And as I said, we still have about 150. So as we went up that curve, as we climbed up that curve, we started opening, staffing empty beds. Then we started to turn old spaces back into active med-surg beds or to ICU spaces, started converting all of our recovery spaces. And so those were all the steps that we went to. And we still had another about 20 beds that we could have used. Fortunately, we didn't have to get to that part. After that point, you do things like starting to turn your operating rooms into ICU rooms. We never had to get close to that kind of extreme level.
Mhm. Carolyn, how about at St. V's?
So at St. Vincent today, we have only 31 positive patients in-house. We have another 20 or so who are under what we call PUIs, or patients under investigation. So until they test negative, we treat them as if they might be positive. So about 50 in-house right now. And I think throughout this, we've always had maybe a third or so of the volume that Umass has. And I think that's proportionate based on bed size. In terms of surge, for us, we do have an ED tent that we stood up. And we stood that ED tent up predominantly to help with surge, but it ends up that we're using it as a rapid way to swab people and send them home who don't have to come into the hospital. So that's actually been great. From an inpatient standpoint, the critical care space throughout the Commonwealth has been the most, the tightest, and it has been the only area that we've actually had to surge into a non-typical inpatient unit. And we did surge into our PACU for a number of weeks. I'm happy to say that we were able to close our PACU yesterday as a surge space. We had that for non-COVID ICU patients. In terms of med surge, we've always had plenty of capacity. And as you're probably aware, a lot of people have stayed away from the emergency department for care that they really should have come for. So throughout all of this, we've had plenty of capacity in the emergency department and med surge. But again, the ICU beds have been quite tight throughout the Commonwealth. So I don't have a step that we reached like Mike does, but the only place we ever needed that surge capacity was truly in our critical care beds.
Got it. And so I know, sort of a question for Richard. There's been a role that Summit Elder Care is playing also for helping to house some seniors tested positive for the virus in a specific facility, the new one on Grove Street. Can you tell us how that operation has been functioning?
Sure. So at Summit Elder Care is a program that Fallon operates for frail elders, and it's designed to help frail elders be at home for as long as possible and to operate and to live independently with support. And so when the pandemic broke out, we needed to begin to start delivering support and care for our members in a different way. And so we have sites, and we began to move more towards bringing the care to our members, our participants in their homes. At the same time, we saw a need, because of our frail elder population having a high prevalence of COVID-19, we saw a need to convert one of our sites, and we converted our new site on Grove Street into an infirmary, a 24/7 infirmary where our participants, once discharged from the hospital but not ready to be home again, could be located and get the support of staff that they're already very familiar with, a program they're familiar with, and also see their loved ones. So that's what we did, and it's a temporary arrangement, but it's one that the flexibility of the model of care for frail elders lends itself to. So we've been very fortunate, and the state has been very supportive of us operating that infirmary.
Yeah, that's great. And it's a beautiful new facility, which makes me think it's a great segue to Reliant, who has built more, beautiful new medical office space in the last couple of years, I think we've all seen. So Dr. El-Sawy, how about Reliant's role, obviously, on your MD staff and so forth, working with the hospitals and other organizations to kind of support that frontline work? Anything to add to this?
Absolutely. We're clearly, much of the attention has been related to what's happening to the most acutely ill folks. But I think most of us recognize the vast majority of the COVID burden is actually in the outlying areas. And one of the things that we sort of took very seriously is how do we help our hospital partners to make sure that we decompress them as much as we can, and how do we make sure that our facilities are essentially ready to be able to take care of whether opening up respiratory clinics. We had respiratory clinics in 4 different locations. We also at one point, in order to actually sort of segregate the patients that may be at higher risk for COVID from interacting with patients who may be in our facility. So that was one component. The second thing, we actually converted one of our urgent care centers into a 24-hour stay when there was real concern that both Umass and St. Vincent's may be starting to hit levels that they'd be uncomfortable with. The third thing was really accelerating and developing our telehealth, not just in terms of video visits, but figuring out a way to actually have a fully integrated virtual care solution. So how do we better engage monitoring for our most frail patients? How do we engage video visits for patients that needed the ability to reach us that way? So there were sort of, we compartmentalized it into making sure that we are segregating folks appropriately, making sure that we had respiratory tents and testing tents, again, in multiple locations, and then also really focusing in on a fully integrated telehealth solution, not just video conferencing and video calls as most folks have started to engage in.
Understood. And I think, virtual medicine is one of the things we're going to talk about when we talk about sort of the transformation that's coming out of this as well. But it really sounds like what you're talking about is that this is the whole system collaborating to support the different levels of need. And while we all wish for no surge in the fall, it sounds like everything that's been set up is going to be ready if indeed that does happen. More ready than we were coming out of the gate in March. So next question sort of naturally says, and this came up from what Carolyn mentioned, is it safe to go to the hospital for other procedures and to your doctor's office, right? And so if we can just talk about what does back to normal look like in your facilities, and how do you, what do you say to those folks who sort of worry about that? Dr. Gustafson, I can see you nodding, so why don't we start with you?
Sure. We've been doing a lot of work and thinking on this. The first important thing is that we're conveying is that we've never been closed, right? So it's important for folks to realize that we've been open throughout this for all sorts of non-COVID care. And so for important chronic disease management, for still a lot of critical ED care. And so we've been equally focused throughout this on our non-COVID patients as we have on the COVID patients. But having said that, when we open up more robustly and have a lot more ambulatory visits and are doing more surgeries, it's going to look and feel different for patients than it did previously, right? So it will start with people knowing that when they show up, they're going to be screened for their symptoms. They're going to have their temperature checked. The visitors are still very restricted by DPH regulations. So unless you have to have somebody with you, there won't be any visitors. The pathways to get to where you need to go will look like the grocery stores with arrows, lots of signage, lots of social distancing built in. When you get to the clinic or your point of check-in, trying to have as much done before you ever show up, right? So using pre-registration, using MyChart, the electronic record, to make sure that you've got everything that you can do in advance. And then have the encounter be touchless. So more verbal consents, doing things like doing the copays by credit card over the phone in advance to minimize that the touching of surfaces. Ideally going straight into an exam room. and then having care be brought to you so you don't have to go to multiple sites, and then facilitated discharge. Realizing that we have certain areas of the hospital where we have the COVID patients concentrated. So if in a large clinic, there's probably 1 or 2 rooms that are going to be dedicated for COVID positive patients. But for the most part, we're going to try to keep COVID positive patients out of the hospital and manage them with telehealth to the extent possible. We don't want to be having folks come in unless they really are sick and need to come into the emergency department. So, and then employee screening. So realizing that on the provider side, we're making sure that every provider checks themselves for symptoms every day, and there's a reporting requirement about that. Everybody is, of course, universally masked, so all patients, all visitors, all caregivers, and hand hygiene really robust throughout the entire encounter. So that will be the new normal for the indefinite amount of time going forward.
Got it. And Carolyn, how is it very similar, I assume, or are there some differences at St. V's?
It's very similar. I'll add a couple of things. You'll see fewer chairs in the waiting room. We are removing chairs. If you've been to the St. Vincent atrium, you wouldn't really recognize it right now because there's nobody doing laps walking around, and the chairs are quite spread out. So we want to make sure that for the people who do need to come, not only are they masked and screened for symptoms, but also that they are safe and they are an appropriate social distance from the other patients or any visitors who might be in the building. In addition to the things that Mike said, we're also working at St. Vincent on a plan for our emergency department to actually separate it into a COVID area and a non-COVID area. And we're working on labeling COVID safe zones as well as COVID care zones so you know which zone you're in. If we do need to do a procedure on a COVID patient who's coming in as an outpatient, we're working on a separate path of entry, and we want to make sure that people feel safe coming to the hospital. It is safe coming to St. Vincent. It is safe coming to Umass. All of our employees and providers are taking appropriate precautions. And we just want to urge people that if you have an urgent or emergent condition, make sure you connect with your physician or come to the emergency department. We've seen too many cases of people coming into the ED who say, I've been having chest pain for 2 weeks. That's not good. We want to make sure people feel safe, and we do have the policies and procedures in place, and we both have the appropriate personal protective equipment and sanitizing materials to make sure that you are safe and can feel comfortable coming to the hospitals in Worcester.
Yeah, there's definitely delayed care. Dr. Alsare, how is that? How are your facilities being presented? And I assume you're seeing that real backup, even with the telehealth.
Absolutely. So I would echo in terms of all the physical and space precautions. That's exactly what we're doing. Much of our emphasis, and really one of my areas of concern, and I'm sure all the healthcare organizations have it, we are starting to see folks who we know for sure need attention. We are actively engaging them with them because the delay in either managing folks with chronic conditions or the delay in making diagnosis acutely that need to be done is really an area of concern. I was talking to a colleague of mine at Partners, and their diagnoses of cancer has gone down by 30%. Well, I think all of us know there's not much good about COVID, and certainly it hasn't done anything to reduce the likelihood of developing a malignancy. So those are the things that are very, very concerning. I am concerned about how we're going to fully engage folks to get back to the screenings that I know are life savings, and for young children who are in need of vaccinations, particularly at certain ages, we need to make sure that those things are done because Lord knows the last thing we need is a surge in another type of infectious disease. So it's going to be very, very important, and quite frankly, our duty and obligation to make sure that those folks we reach out to and make them feel as safe as possible. I know I feel a whole lot safer being at any Reliant facility, and I'm sure I'd feel the same way about a St. Vincent facility or a Umass facility than I quite frankly do going to the grocery store. So because the precautions that I see and the way people are behaving in the healthcare setting is really vastly different than anywhere else that I've seen.
Are you going to be opening a produce section at the Reliant?
You know, we're thinking about that
Farmers
actually.
market?
You know, I think we could do that. I think we could.
We had groceries to go for our employees, so because they could pick it up easily in the cafeteria. Hugely popular.
Yeah.
To make it.
At St. Vincent, we do as well. We even have toilet paper available.
Yeah.
Oh, that's fantastic. So, Richard, I know you've got sort of a lot of professional office staff, and you've got direct facilities. How are you balancing that sort of back to work and keeping those other places as welcoming as possible?
Sure. So we have been open and operational, as I said earlier, and so we're putting plans in place now that the governor has announced his plan and his phased approach. But we won't be the first to return to work in our offices because we've been able to operate effectively remotely. And so we're going to take the time and be deliberate and thoughtful about making sure that all the precautions are in place to allow us to return to the office. In addition, we'll be following very similar protocols at our Summit Elder Care sites and at our site in Western Mass in New York, as were outlined by the others on this panel. But it's really important. What we're doing for our members is sharing information with them and encouraging them to seek medical attention if they need to. And I think what was just outlined by the others on the panel is incredibly important for us to share with our members so that they feel comfortable seeking out the care they need. So one of the key things that we're doing at Fallon is communicating with our members. And an organization that we belong to, a national organization, just released a study this week in which they found that 38% of people surveyed said they were going to continue to delay seeking care. So I think communication can't be overdone at a time like this. So we're certainly going to do that with not only with our members, but also with our employees.
Got it. So here's a question. So when we talk about people going into the hospital or doctor's office and all that, we know that there is anxiety there. And another word for anxiety is sort of the whole category of mental health. And, Carolyn, in speaking yesterday, we talked about some of your frontline staff just, having heartbreaking experiences with, the deaths and the level of sickness and the lack of access to family at the very front lines. But I think those stresses are felt at a lot of levels by folks. How have you needed to respond to that internally? And how do you see that sort of mental health issue as sort of growing and needing to be dealt with in the, the mid to longer term? Michael, if you wanted to give us your insights first.
Sure. So I think there's a couple things I'd emphasize. So the toll of mortality it's really striking. And whenever I am going around and do rounds with staff, people that have been in the profession, ICUs and EDs for 30 years, will say this is the most amount of death that they've encountered in their entire career. Right, a number of people dying in one day compared to maybe what they experienced in a month. And so having folks be able to deal with that kind of cumulative stress and anxiety, not only that, but the dying process itself has been really probably one of the most difficult parts of this experience. And that's both for our COVID and non-COVID patients, but particularly for our COVID positive patients who are at end of life. For the first month or so of our program, we were not able to allow family and visitors to be with those patients. So the caregivers literally were the last people trying to make that moment, as meaningful as possible for that family member. And a lot of caregivers said that was the hardest thing that they've ever had to do. And so we were really committed. We created a new program called End of Life Navigator. And we figured out a way to get at least one or two family members at the bedside for at least like the last 30 minutes of a patient's life, so they were able to say goodbye. And the caregivers found that to be incredibly helpful. That's just one example of the amount of stress. our approach generally has been to go out and be as proactive as possible, doing rounds. Members from our psychiatry department, our psychology staff, care workers, social workers, engaging staff on how you're doing and what's your level of stress, what's your sleep condition like, and then trying to help them either with peer support to talk to each other or connect them with the right resources. Different people need different types of things. Some people really respond to meditation and relaxation types of resources. Some people want to talk to peers, and some people want to talk to a professional. We're trying to make that whole spectrum available, and not just now, but what might come over the next several months as things settle down. Kind of a post-traumatic stress condition is what we need to watch out for as people recover from this.
Dr. Alsari, what about the Reliant Group? What's your
So,
experience?
I think I'll echo a lot of what Michael said. Obviously, the intensity that folks who are in hospital ICUs is very significant, but we also have multiple folks who are hospitalists, et cetera. But I think the one thing that I'm always looking for bits of good news, and one of the bits of good news here is, in a counterintuitive way, I think most of us would have thought telehealth would not be all that amenable to something as personal as having a behavioral health issue or addiction issues, et cetera. Of all of our service lines, we actually were able to go from the normal visits to telehealth visits in 48 hours, and the entire department did that. We have found that actually the telehealth visits now exceed what our pre-COVID numbers were, and the amount of folks who are engaging in telehealth with higher patient experience than they did in any other setting has really been, there was literature about that, but it was sort of almost hard to fully believe. But we now know that this is absolutely a part and parcel of the solution long term, particularly for people who are challenged with getting to us, for people who simply couldn't make the time. So things like our no-show rates have plummeted in behavioral health, and folks are actually much, much more likely to engage with it. So that was sort of on the patient side. So when we saw that, we actually opened the same forum specifically for our providers. And that really has been one of the very best things we've done. I echo Michael's points. I am very, very concerned about the long term. Right now, everybody sort of has an adrenaline rush and is getting through things as best as they can. But the post-traumatic effects, I think, are going to be the thing that we really, as an industry and a community, have to be absolutely aware of. We're trying to do all we can, but I think it's the one area where we absolutely have to double down.
So, Carolyn or Richard, did you want to add to that discussion?
I just wanted, the only thing I wanted to add, and I agree with what's been said, but it's so important also to celebrate the positives. And there's so much negative, and we have so many critical patients and challenging stories. I send out an email to the entire staff as well as physicians. It goes to about 3,500 people every night. And I've been doing that since March 15th. And for over a month now, I start with the positive stories of the day. And yesterday, for instance, we had a code strong, a positive patient who was discharged, and he loves fire trucks, and we had the Worcester Fire Department come out to celebrate that. We're coming up on our 200th COVID discharge, hopefully in the net. We're at 183, so hopefully we hit 200 soon, and we want to celebrate. So we want to make sure we're certainly not ignoring the behavioral health pieces. We are absolutely providing the supportive pieces, some of which have been described, but we want to make sure that people see and are able to celebrate the positive things. So we're trying to have a balance of supporting and making sure we're showcasing the good.
I think Carolyn makes a great point, and I agree also with everything that's been said. We've received at our Summit Elder Care program, we've received incredibly positive feedback from family members who have loved ones who have tested positive, and many have made it through it, and unfortunately some have not. And what we're planning to do is to hold memorials at all of our sites for families, as well as our caregivers who, who also, as Dr. Gustafson said, they feel the toll of the mortality. And so what we will be doing is holding memorial services in the weeks and months ahead. But it's a very difficult time for the caregivers, and my hat's off to the frontline staff that have to go through this day in and day out, and really are stepping up.
So, Dr. Osawa, you just mentioned our next kind of topic is what has changed in the business, and kind of the two themes maybe we can just tease out just a little bit. One, virtual medicine. We've, rolled it out at such a rapid rate by necessity, and now you're seeing real stickiness, if to borrow a website term to that, and other innovations and things that would take months are getting decided and moving. Innovation, virtual medicine. What else sort of has been kind of the positives that have come out of just the organization responding in the way it's needed to? Dr. Osawa, if you want to start.
Sure. I think the digital platform is clearly a clear thing that's happened. And I think one of the points that I want to sort of emphasize there is it was not just sort of the provider acceptance, but really the crucial thing that happened is finally it took a pandemic, but now people really have an appreciation of all the things that you can do virtually. And that's been very encouraging. There are still some real issues with that. There is some real disparity and lack of equity in some ways in terms of what some elderly folks and others in the community have been dealing with, whether they're technologically challenged or it's not as straightforward as people think. Not everybody has the ability to do that. So I think that's something that we have to continue to work on. And there are some innovative things that are being done, and some of them we're going to be doing with our payer partners in terms of to make sure that we're working on that and getting folks that really need that access, who are the least able or the least financially able to utilize that type of technology. We want to make sure that we get that to them. The other thing that I would really highlight, and people describe it as innovation and creativity, I think a lot of the boundaries that people had before in terms of thinking about how to solve a problem have literally disappeared. And part of that has been some of the regulatory burdens have been removed. I remember calling Richard and saying, hey, look, we're thinking about doing XYZ. Would you be supportive of that? And that was to allow us to sort of help decant some things away from the hospitals. And, he basically got back to me very quickly and said, absolutely, we can do that. We had very, very similar conversations with the state. So a lot of things that had historically been barriers or stopped people from thinking about it evaporated. And that to me is something that I really hope we can continue to push forward.
Got it. Other insights on that sort of what's changed inside your organization?
I was just going to add a couple examples of the telehealth out of just the kind of the ambulatory visit, as we often think about. So in the DCU in the field hospital, I was really impressed when I learned that we were using wearable monitors there. And we figured out a way to send the patients home with their wearable monitors. And then the staff were checking in with them at 24, 48, 72 hours, measuring their oxygen level, their heart rate, et cetera. That technology has been out there, but we were able to figure out how to actually do it very quickly in a really concrete application. So I was impressed by that. And then using telehealth on the inpatient side for connectivity of patients with their loved ones, but also with caregivers, with family members. It really enhanced, I think, and made our communication, because we were consciously focused on trying to make sure that there was connections, actually better than it was on a regular basis. So how can we carry that forward and make sure that we're leveraging that technology in that setting, or just our focus on better communication with the family and the patient?
So in addition to that, and it's definitely not telemedicine, but it does involve video. One of the things that has been a challenge for all hospitals is COVID patients need to be in a room with the door closed. And so you are typically, most of your patients, you typically have the door open, especially if they might be elderly and a little confused. And so somebody had the idea of using baby monitors. So we actually have really high resolution baby monitors that we can put in patient rooms. And if they are somebody who we think might be a fall risk, we can actually visualize them prior to the bed alarm going off so we can be able to better intervene. And it actually helps us because it's easy two-way communication that doesn't necessarily involve the nurse call station. So there are things along those lines. In addition, any ICU you go through in the country right now, you'll likely see the IV pumps outside of the patient room. Normally they'd be in the patient room, but because you have to put on so much PPE to go in, if the pump starts beeping and you need to make an adjustment, you want to be able to do it quickly so you have that outside the room. So there's things that we've adapted, and some of them have been staff ideas, some have been like the IV pole, we got it from another organization, but there's been so many hacks, if you will, and I have this that I show on some of these webinars. This is something that you put behind your head and put your mask on so that your mask attaches to this rather than hurting your ears, because a lot of people have a lot of pressure on the back of their ears. So there's just countless examples of really neat innovations of ways people have made this as easy as possible to do something that's really, really difficult.
No, I would add that there, in addition to the telehealth, which it's not going to go away after the pandemic. I think consumers become very comfortable with it, as you know, as Tarek said, in the behavioral health space, as an example. So we have seen at the health plan a dramatic increase in the number of claims related to telehealth, and in fact are encouraging our members to seek care that way. And I think that will continue. In addition, I think that our programs for frail elders and some of our other programs, which emphasize delivering care in the home or addressing the social determinants of health that often lead to a hospital admission, a visit to the emergency room, et cetera. I think the need for those programs will increase. So I think that post-pandemic, we're going to see a lot more people being interested in those kinds of programs which bring care and support into people's homes where they feel safest.
Got it. So my next sort of topic is community collaboration. And Dr. Alsauer, you mentioned just kind of getting Richard informally on the phone and not having, a 6-month review, right? And just the two of you being able to work things through, and, the hospitals coordinating. We're in Worcester and we're in central Massachusetts, and we all know there's a strong sense of community. For you and your organizations and some of those frontline folks, what's that been like working with peers, working with businesses, and having, what's the heartbeat of the community? How's that sort of making its way into your organization? If you can just share a couple of stories about that.
Well, I can sort of share a couple of very simple examples. When Umass was charged with, first of all, the thing I would say is I am truly honored by the level and professionalism and the sense of empathy of everybody that I've had a chance to work with, whether it was folks from Umass or from St. Vincent's or payers, or quite frankly, some of the cleaning company. I mean, so everybody really chipped in, and that was incredibly heartening. But we had some very, very concrete examples. When the folks from the DCU, when Umass was in the process of creating and working on creating the DCU for surge capacity, we asked for volunteers from our staff to help them because the call was made that we may not be able to staff it fully as it is, and we were asking for 20-some volunteers, and we got 58. When we were trying to have our urgent care center be open for overnight, which is something that it had not done before, we needed 40. We got 84. So the sense of people wanting to help and wanting to actually feel like they're contributing in a positive way was overwhelming. But I think I keep sort of going back to the fact that so many of the barriers were broken down quickly. We asked Umass to help expedite some things in the rapidity of test turnaround, and Eric was extremely helpful. So so many examples of that where people really stepped up, and the answer was not, hey, let me get back to you. The answer was, sure, let me figure out how to do it. And I think that to me is something that I really hope stays as much as we can make it stay.
Got it. And what's it, so Carolyn, at St. V's, how has that felt? I know there've been flyovers for nurses and a lot of anecdotal great supports from area businesses. And if you can just tell us how your team is feeling it.
Yeah, in addition to the flyover for hospitals across the state, we had a parade of EMS that was, I think, organized by a UMass security officer. And that was phenomenal. That was over a month ago, I believe. And overall, the community support has been fantastic. Before the homeless shelter opened up at the technical high school and before the DCU center opened up, I was called into a meeting with Mayor Petty and City Manager Augustus and Eric Dixon, and we began to collaborate. And since then, the support and collaboration, especially between St. Vincent and UMass, and the number of texts and calls that have come from the mayor's office, just asking if we need help and seeing what they can do to better collaborate has been phenomenal, as well as certainly other elected officials. In addition to that, the donations we've gotten from the community and the outpouring of support has been amazing. Just yesterday, we had T-shirts delivered from Worcester State. We've had all sorts of food deliveries, whether they be the restaurants who are doing the donation themselves, or somebody placing an order and saying, I want them directed to a certain unit, or even for the whole hospital, has just been phenomenal. We've gotten thank you cards and notes, sometimes drawings from kids, sometimes heartfelt notes, and even just some woman sent us 50 cards that she had written a happy birthday note, a get well note, or a best wishes note for us to distribute to patients. So just the thoughtfulness and compassion that people are showing for our patients and our healthcare workers has been phenomenal. And I can't say enough about just the kindness of the Worcester community. It's truly been amazing.
So Carolyn, I think we should send that testimonial into John Krasinski's Some Good News, and maybe we can get you on the YouTube broadcast. That sounds
Sure.
great. Michael, in terms of UMass, obviously you folks are in the middle of that.
Yeah, I would just add that, I've been in the Worcester community for 20 months now as the head of UMass Medical Center. And I've been totally blown away during this by the amount of community support. And starting with early on, the amount of donations around PPE, which was amazing, and then turning into all the food and the expressions of gratitude from the community and all the other displays. So that's been wonderful. DCU was a perfect example of a multi-party collaboration to get things done really quickly. City, county, state, hospitals, provider groups. There's not a better story there in terms of how we were able to pull that off and be the first in the state to do that successfully. So I've been really, really happy, and we're incredibly grateful for the community.
Got it. Richard, I know you guys are a pretty active community organization.
Yeah, so we are, and the Worcester Together Fund has raised millions of dollars, and I think that's a testimonial to the community collaboration that runs across our entire city and our region, and we're really proud to be part of that. But when we converted our Summit Elder Care site on Grove Street to an infirmary, we knew we needed more PPE, and UMass sent us hundreds of face masks. Just sent them to us and said, if you need these, they're here for you. In addition, we needed to test our staff before they were going to care for our participants there, and Reliant Medical Group, Occupational Medicine, opened their doors and said, come on over and you can have the testing done here. So again, I think those are examples, important examples of what's very real in our community. So yeah, it's a great community, and I think this has brought out the very best in the organizations and the people who live here and work here.
For sure. So since this webinar is being brought to you by, in part, the Worcester Business Journal, I have to ask some business questions, right? And that's about finances and employment. And so when you look at sectors in the region, the healthcare sector is our largest single employment sector. And there's a lot of jobs, Umass employer in the region, and all of you on this call among the top ones. So, you know, how are you doing holding on to staff, and how are the numbers? What's the financial impact, and how do you respond to that? Who wants to start with that one?
Oh, I can jump in. So, going into at the end of 5 months for February, we were actually on track. We were on budget, slightly ahead, doing well, hitting our kind of growth projections. In the month of March, with the pandemic, we lost about 25 million. And then the month of April, which we just finalized, is another 45 million. So at this point in the year, we're about 75 million negative. And that's with the part of the state and the federal relief already being flowing through and being booked. And so by far, this is going to be our worst financial year in the history of the institution for the Med Center and for the system. In part, it will depend on the extent of the second or third waves of funding from the state and the federal government. Having said that, we have tried extremely hard to make sure that we could preserve all of the jobs for our employees at their base salary. And so far, we've been able to do that. Part of that was because we were able to redeploy hundreds of people from their normal area, let's say our ambulatory clinics that went down to less than 50% of their normal activity. All of those folks are out and supporting new functions, whether that's the ambulatory drive-up tent for testing, or our ED tent, or they're on the floors supporting our ICU nurses and our doctors in many different ways. So literally hundreds of people that are now doing new jobs, new roles, working with new teams. We've had several hundred that we didn't have work to do that we've been able to support with administrative pay. That ended last week. We have everybody back in the institution. So that's been our strategy. We've been able to hang on to that. And now we're looking to, as the state reopens, to ramp back up activities in each of our areas.
Got it. Dr. Elsawa, you're Reliant's part of a larger organization. So how does this roll through the local?
Yeah, I think this is obviously being a part of Optum and the larger enterprise has been extraordinarily helpful. Quite frankly, I think if we were not a part of it, the level of distress we would have felt would have been extraordinary. That said, we have been able to keep all of our employees whole. And for many who are on the front lines, we actually were able to do some things to augment their income, predominantly as a very, very small token of gratitude for the incredible work that they've been doing. But I think we clearly we were doing well going into February, and then by mid-March, things started to change dramatically. Many of our services, particularly in the surgical and procedural arena, essentially came to a full stop. So that's been a dramatic impact on our finances. But I've been extraordinarily proud of the overall response. Optum and UHG have been, quite frankly, phenomenal in terms of the level of support, not just to us, but to all of our care delivery organizations across the country. So we have been sort of protected somewhat in what we're able to do. But I think we continue to reimagine our business, and we had put ourselves in a position with some of the changes that we talked about to continue to maintain as much of the business that we wanted to be able to maintain in terms of seeing patients, but in different ways. And I think it's given us an opportunity to think forward about the things that will actually, in some ways, may actually position us in a position of even further growth.
Sounds good. And so, Carolyn, when we were talking yesterday, you mentioned sort of a number that all state hospitals were losing, and it was rather large. What's been the impact on St. V's operations, and how do you see things going forward?
So, and the number we talked about yesterday for the state of Massachusetts is $1.6 billion per month. And that's a $1.6 billion loss per month of all hospitals together. So that's really staggering when you think about the hospital industry, the jobs and everything. And the federal funding is really a drop in the bucket with all the losses. And in terms of St. Vincent, similar to Reliant, we are fortunate to be part of a larger organization. I know that hospitals that are standalone, that are not part of a broader company, are really having difficulty with PPE and having difficulty maintaining operations. And so that's something that I'm very fortunate. I will say one thing that we've done within our company is everybody from the CEO level up hospital CEO level up, I should say, has donated a portion of their salary over at least the 3-month time to a fund that employees who are having some type of financial hardship related to COVID can apply for and get some financial benefit to help them through that difficulty. And there's a group who screens those. So we've been really fortunate in that as well. But it has been challenging. And again, the numbers statewide and nationwide, the losses are really just staggering.
Got it. And Richard, from the health insurance perspective, but you've got a lot of other programs as well. How's that impact been?
So our first quarter, which ended in March, performed pretty much as expected, but it was really only in March that we began to see the impact of the pandemic on our claims. So it really is in some ways too soon to tell. We've obviously seen as revenue has declined at the hospitals and the providers, we've seen a decline in our claims for outpatient visits, optional procedures, and so forth. However, we have seen a sharp rise in prescription drug costs, and we're now starting to see the claims related to COVID. So in many ways, for us, it's too soon to tell. And for Fallon in particular, because of our mix of business, where we are heavily not only in commercial business, but also Medicare and Medicaid, we're going to have to see how this all plays itself out over the months ahead. So we're watching it very closely, but we're certainly seeing some things, some claims, areas of claims dropping, while others have increased.
Got it. So I'm going to skip over the Massachusetts back to work question. We're at 1:58, but I wanted to give everybody some kind of the chance to give a summary on kind of how you see the future. And specifically, we talked about what fissures in the system has this crisis exposed. You know, we mentioned Medicaid's low reimbursement rate, and mental health is sort of a, you know, what cracks in the system really need to be, is this exposing, and then maybe what positive thing that you think could come out of it. So, you know, the darker side of the future and the lighter side. And why don't we ask Carolyn to go first here?
So I think one of the things, and this isn't necessarily a healthcare piece, but I don't know that any of us ever really thought of a time when we couldn't depend on a national shipping company to deliver on time. And that's been something that has failed us multiple times. I think we've seen it in our personal lives, but certainly we've all seen it in our professional lives where we're expecting a shipment of something and it's a little delayed. And thankfully our operations weren't hampered by it, but we came close a couple of times. And so making sure, I heard a newscast about something the CDC was saying today, really making sure we are over prepared in the future. And this situation has stressed the system like never before. And so going forward, making sure we are over prepared. On the bright side of things, I've been wearing scrubs and a St. Vincent logo top for the last 2 months, which has been great. And I've spent a ton of time out in the hospital, talking to staff, talking to doctors, reassuring them, listening to their concerns, and the relationships that have been formed across the organization have just been phenomenal. So I really want to make sure we're able to keep that spirit of camaraderie, collaboration, and innovation that has been sparked by the COVID crisis, and make sure that we continue some of the good that has come out of this.
Got it. Richard, you want to go next?
Sure. I mean, I've been like Carolyn. I've been really inspired by our employees who have made this quick transition to work from home while juggling new family responsibilities with schools being out, daycare being closed, and yet still making our members number one in terms of their work. So I've really been inspired by that, and I think that's been really heartening to see our employees go the extra mile. I think a big shift that we're going to feel for a long time until the economy recovers is the growth in the Medicaid population. And so I think we need to watch that very closely. It will impact hospitals, it will impact providers, it will impact managed care companies, and it's a very significant issue. It'll impact state government budgets. So there is an expectation of a very large shift from employer-based health insurance as people unfortunately lose jobs and then eventually move into either uninsured, which I think Massachusetts won't experience as much, and more likely into Medicaid.
Got it. Dr. Gustafsson?
Sure. To your first question around like what fragility has been exposed, I think this has been a perfect case study to show that, the healthcare reimbursement system is so heavily weighted on things like elective surgical procedures paid at a higher disproportionate way than so much other care, or the commercial payments so much more than the government payers, right? And when you have a sudden shift of the business away from commercial, elective, high-paying things, it exposes how fragile so many hospitals are just to survive on already really tight margins, right? So I think that's been good public policy discussion already about that. The one thing I would say for us that I'm most inspired by, or the most positive, is we're really proud that we were first in the state, first in the region for 2 really important treatments. So being part of the first clinical trial around remdesivir, the antiviral, the first 31 patients in the national clinical trial that then was opened up, saying it's showing some positive results in reducing recovery time, and now another 60 patients. So we've had almost 100 patients treated with the antiviral, and then already about 100 patients treated with convalescent serum, the first in the state of Massachusetts. So we should all be really proud that Umass was able to deliver that in Central Mass and really have the best cutting edge treatment for the people in this part of the state. So I'm really proud about that.
Fantastic. And Dr. Elsawa, you get to be the closing speaker.
Well, that's a heavy burden, but I'll do my best. So I think there are really 2 things in terms of the fissures that we saw, or the breakdowns in the system. I think Michael and Richard really hit on 2 very important ones. One, I think we have to buttress our Medicaid programs. I think that's clearly become evident. And I will always put in a plug for value-based care, where I think this has really exposed a lot of the issues that are associated with the traditional fee-for-service business. I don't think it's good for most folks, and this has clearly exposed that. But my optimism far exceeds my pessimism about some of those other issues, which I think are policy issues that eventually will be worked out. I think it is undeniable now that everything that we do really needs to come back to great science, to great bench research, to great clinical work, because that is going to be the thing that will truly lead us out of this. And I'm not talking about lead us out of it just from a healthcare standpoint. I think it will be the answer to economically how we get out of this. While all of us are taking great precautions about, making folks be comfortable when they come back, I think, to me, this is about ultimately, I do believe science and innovation will win. And I'm very, very convinced that that's going to happen sooner rather than later.
Terrific. Well, great wrap up. And I'd like to thank all of you for a really, really rich conversation. A couple of the questions came in, just wanted to confirm where folks could get this recording, and that will be on Worcester Business Journal's website. Everyone who registered will be sent a link to this webcast so that you can either watch it again or send it to a friend. I want to thank, to make that possible, our sponsors, Webster 5 and Fallon Health. And again, Carolyn, Richard, Tarek, and Michael, thank you again for a great conversation.